My lecture is more slightly historical, and Stephen will be doing an update in his next lecture as well. And as Nelson Mandela once said, if you tell me where you're coming from, then I'll tell you where you're going to. So for those that don't know the history of dermal filler management over the years, I suppose I've been slightly opposed for quite a period of time to the methods of retrobulbar and advocating supraorbital when it was a lone flag that nobody wanted to fly with me. And I suppose myself and Jean Carruthers, who brought in retrobulbar in 2012, were at slight loggerheads. We communicated with each other. And at IMCAS, for those that weren't there, Jean now also agrees that maybe we should give up on retrobulbar and go down the supraorbital route. So I'll just give you a quick background to that and management as well. I have no disclosure, and we know that sort of dermal filler-related blindness is quite a rare condition, but unfortunately, of all the complications, it's probably the worst one. And we all have our opinions regarding management, and we're so lucky to have such esteemed ophthalmic surgeons among us. Gabriel just left, but John Martin from Miami and Sandy from California. I'm not missing any other ophthalmologists there, I don't think. You're a vascular surgeon. Oh yeah, of course, that's true, yeah. So in terms of blindness, it's been coming for a long time. We don't, I suppose, realize that we had blindness from dermal fillers back in the 1950s, and that was mostly from fat, I suppose, at the time. Our colleague from Brazil so wonderfully demonstrated through all the different images that he had, the vascular anatomy and how it can happen. But normally we would assume or know that it happens through one of these 5 different ways. Number one, I suppose, through the cutaneous branches, that's through A. B, below, is through a remote site connected through anastomosis. C is the possibility of an AV shunt that could happen to it. And D and E is the orbit between the ophthalmic artery and the vein itself. But most of them we know comes from A. This is the geographic distribution of cases around the world. And you can see some of them include Britain and Ireland that I've sort of been involved. I've been involved in 3 cases of dermal filler blindness, including Sweden, England, and actually 2 in Britain. And you can see that there's a high propensity in China, Korea. Most of those come from nasal rather than glabella or temporal, as the cases the certified deal with. I'm surprised there was quite a high number in the United States, actually, because I remember many years ago when I think it was Arthur Swift identified, there were very few cases in the US then.
But there are a lot more injectors now.
Of course, yeah, absolutely.
More people,
yeah,
more things.
More problems, like everything in life, absolutely. So you can see the nose is by far the most common site of problem, followed by the forehead, glabella, nasolabial fold. I'm surprised even lip can make it all the way up. So this is a slight history of myself. In 2007, it's nearly 20 years ago, in sort of at IMCAS in Paris, we still weren't using hyaluronidase very much, but I was interested in Joel's paper yesterday that showed he'd reversed the vascular occlusion in 2007 back then, because hyaluronic acid fillers weren't widely used in the United States in the period 2005 to 2007, where we were using them probably in 1996, so we had a lot of experience with them. I was chairman of the Royal Society of Medicine back then, and we had our first case by a colleague of ours, Lucy Clancy, that was doing Sculptra just in the temple area and created a blindness. So we were in early with that, but the patient at that stage was a few months blind, so there was no recurrence. Early on, this is something for Las Vegas back in 2007. 2011 was it? I'd advocated the supraorbital method and how to do it. We suppose we don't have to go into to thing, but the nerve block and the route to the vascular was the same one. Las Vegas, 2014, myself, Claudia Lorenzo, Corey Mass, Stephen Dyan, Neil Sadek had proposed the higher doses of hyaluronidase because we were in lower doses of that. That was Jean's first paper with Katie Belancy, and they've updated that, which is wonderful, in 2023. So that was, I suppose, the first time that, and it's quite normal to think ophthalmic surgeons would go for retrobulbar because that's the natural route that would use for, I suppose, anesthesia, particularly during cataracts. But whether at the time there was a direct route back into the CRA and ophthalmic artery, a couple of us queried whether this would work or not. And as time passed, we noted that it didn't really work.
By the way, that was my cataract coach back at,
all right.
That's Uday Devgan's video, and he taught me cataract surgery back in
That's incredible. It's wonderful the way that history all joins up, isn't it?
To all of you, that could have been my scrubs.
Ah, that's wonderful. 2015, I sort of had expressed my opinion in that magazine, and, I had said that my reasons for rejecting the ophthalmic risks were too high, vision rescue was unlikely, and the central retinal artery outside the nerves where the embolus would be lodged. I'd advocated, I suppose, the supraorbital at the time. In Paris, I'd come out as well and said, these things are going to happen to people that don't have knowledge or specialized knowledge of ophthalmic surgery. And as a consequence, it should be a bit like fixing a heart attack. Everybody should be able to do CPR. And this team, Isaac team, have some wonderful protocols that brought forward now, and particularly Sandy has been very proactive, as is Tanya and Heidi, in terms of producing a protocol that we can show to the whole world, translated into Chinese, into Arabic, into Spanish, and into English. So like CPR, it should be something simple. Everybody can do chest compressions, and there isn't a terrible difference between embolization of the central retinal artery and a thrombose vascular occlusion of some of the coronary arteries. Anyway, I was heavy into the supraorbital method. I'd written letters to Prime and all the rest. And then a colleague of ours reversed one in Geelong at the time. And Greg Goodman is part of our group. That's Mike Clegg, his nurse at the time, who presented in Paris. And that was a straightforward thing. I'd won myself, but I didn't want to claim it because the patient was actually getting better by the time I seen her. She was a half an hour into it, and I debated whether I should actually try and sort of make her better or whether I was using her for target practice. It was sort of an ethical decision, so I decided to actually use a Botox needle, flooded her with hyaluronidase. I get 1,500 at the time in 1 mil. And the patient did get better. She restored her total sight by the time she'd reached the hospital. But I seen her half an hour into it when she was actually getting better. So I didn't want to leave it outside our team. I told a friend of mine who was in the hospital, but I left it at that. This was an interesting case that I was involved with in the Karolinska Institute in Sweden. Now, I'm under legal obligation not to mention the case. When the patient got, I suppose, paid off, part of it was that we all signed an NDA that we wouldn't mention anything more about it. But the thing was that she originally had her MRI didn't actually show it there. It showed it in the cavernous sinus. But the second thing was we decided to take another look at it from the point of view that her retina was damaged, whether we could actually use the period of damage to the retina to maybe reverse it with stem cells. Now, we knew in Miami at the time there was a doctor who had reversed blindness, but when I looked at him, the patient had multiple sclerosis. So, I mean, she's probably going to get better anyway. They go through a period of remission and relapse. Oh, I'm over time, am I? So we had decided that maybe we should use stem cells with Alvaro Scoopin, but she was a Caroline Institute patient, and you all know from Netflix that Paolo Vaccarini had done stem cells. His patients had died. They'd made a Netflix movie about it, and as a consequence of that, the Caroline Institute pulled out at the last thing. We went through 2019. A lot of papers from China said retrobulbar doesn't do anything. We should give it up. And I skipped through this. That's an update. Jean's paper. She sort of put her hand up and said, yeah, we should do supraorbital. This is a case that was reversed as well. Even though I put it down to Fernando, it was Paula, another colleague, that did it. And I only mentioned it quickly because where we are also is with a colleague of ours, Ha Hong Nguyen, who's in our ISAC group, and he had taken, is there any volume with that, please? Any sound?
Effective. Why? Because the central retinal artery is stay in the middle of ophthalmic nerve and is protected by the dura mater. And so the hyaluronidase very difficult to infiltrate inside the central retinal artery.
So he used.
So it's you see on the
cannula.
microdissection that the central retinal artery is 0.4 millimeter, very small, and stay deep in the optic nerve and protected by dura mater. Is the reason it's very difficult to go inside.
Heidi can't understand his accent.
No, I said I think it's easier here if you speak.
Oh, I see. Okay. So he cannulized, I suppose, the ophthalmic artery up to the point of the CRA. The cannula was too big to enter it, but he had about 10 cases that he reversed. Some of them got complete restoration of sight, some of them had partial. And I know when John's talking, he's going to say that maybe some of the patients don't have full occlusion to start with. Actually, I'm running over, so I'll leave my talk just at that, maybe.
That was great. Now, I just felt you could summarize it for us better. We can understand you. Thank you. That was wonderful. And I think what's so important is hearing that history of where we've been and where we've come. So thank you.